Welcome back to the Deep Dive. Our mission today requires, well, almost surgical precision itself. We're dissecting a stack of expert sources outlining operative obstetrics protocols. Our goal is to give you, the learner, a real mastery-level understanding. We're moving past just basic definitions here. We're really drilling down into the non-negotiable details, the clinical thinking, and the sheer precision needed in these procedures. Everything from, minor manipulative techniques right up to major abdominal surgery like the Caesarean section. This is about learning the field like an elite professional.
That's absolutely right. Mastery in this field really hinges not just on technique, although that's crucial, but on strict adherence to protocols. Today, we are going deep. We'll cover the required surgical precision, the absolute necessity of asepsis, the specific indications that justify stepping in, and really importantly, the rigorous management strategies for high-stakes complications. Think uterine perforation, for example.
Okay, let's unpack this. Where better to start than the absolute foundation of surgical safety, the protocols of the operating theater?
Right. So when we talk about any operative obstetrics, and that term covers a huge range of things, the cornerstone is, well, it's unwavering. We have to adhere to strict asepsis and antiseptic precautions, always, irrespective of how major or minor the procedure seems.
That detail really jumps out. The sources are so clear that this rigidity applies even to things that might seem routine, like an internal exam late in pregnancy or during labor. It still demands the utmost asepsis. Why is the protocol so absolute there?
It's fundamentally a prophylactic measure, and it's rooted in anatomy. When you introduce a finger or an instrument vaginally, you risk pushing normal commensal flora higher up into the tract. And if labor is prolonged or if there's any manipulation after that, that lack of asepsis immediately boosts the risk of ascending infection. We're talking potentially life-threatening chorioamnionitis or puerperal sepsis. There's just no acceptable compromise.
Okay, so beyond infection control, there's this need for critical awareness of anatomy. The sources mention the bladder and rectum specifically. Before any procedure, their proximity has to be accounted for. What are the specific steps that follow this kind of anatomical check when you're prepping for, say, vaginal operative or manipulative obstetrics?
Well, we proceed with a very standardized checklist, really. Starting with anesthesia. The choice here depends on the procedure, the urgency. It could be general, local, or for some minor procedures, maybe conscious sedation using intravenous diazepam.
Okay, anesthesia first.
Yes.
Then positioning. The patient's placed in the lithotomy position, which is essential, right?
Yes. The lithotomy position gives you the maximum exposure to the operative field. It's standard. Following that, we kick off the surgical asepsis steps. This is a non-negotiable checklist. The whole surgical team has to wear a sterile cap, mask, perform a really thorough hand wash, and then get into a sterile gown and gloves. That maintains the team's sterile integrity.
Right, the team first, and then the focus shifts to the patient's immediate field.
Precisely. The external area, the vulva, the vagina, is swabbed really extensively with an antiseptic solution. But, and this is a specific point in the sources, there's a separate step just for the cervix. It has to be cleaned with a povidone iodine solution, getting right into the canal. That distinction really shows the focus on stopping any upward migration of surface bacteria.
Okay, cervix cleaned specifically. And finally, the area is set up with drapes.
Exactly. The perineum gets draped with a sterile towel, and the legs are fitted with sterile leggings. This clearly defines the sterile operational field, which, has to be maintained throughout the whole procedure.
This brings us back to the anatomy you mentioned earlier. How is the bladder managed before things get started?
Bladder management is crucial for two main reasons: preventing injury and ensuring the bladder is deflated so it's just out of the way. If the patient is able to walk, they must empty their bladder immediately beforehand. If not, then catheterization is required. Failing to empty a distended bladder, well, it risks rupture or direct injury during any operative manipulation. It's a basic safety step.
And the very last step before the action begins. What's that final check?
A final vaginal examination is always performed. Always. This is the ultimate confirmation. Uterine size, position, cervical status. It makes sure nothing vital has changed between the initial assessment and getting everything sterile. These foundational protocols, they aren't just bureaucratic steps, They are the safety firewall against the most common surgical risks.
Okay, let's transition now. We're moving into procedures specifically for clearing the uterine cavity, starting with dilatation and evacuation, or DD. So this is dilating the cervix, then evacuating the products of conception from the uterine cavity. The sources lay out two distinct approaches, the one-stage and the two-stage operation.
Right, and the choice between them really hinges on the clinical context, specifically the state of the cervix and, well, the urgency of the situation. The one-stage operation is just what it sounds like. Dilatation and evacuation happen at the same time in the same sitting.
And when is this more rapid approach indicated? What sort of situations?
It's most common for an immediate issue, like an incomplete abortion. That's probably the most frequent use. Other indications would be inevitable abortion, medical termination of pregnancy MTP, specifically when it's done between 6 and 8 weeks gestation, and also for managing a hydatidiform mole that's already, actively in the process of expulsion. The procedural steps are very specific here.
Walk us through those key steps involving the instruments.
Okay, so the patient's under general anesthesia. A Sims posterior vaginal speculum goes in first to visualize the cervix. Then the anterior lip of the cervix is grasped firmly with an Alice forceps. This is really essential for providing traction and stability while you're dilating. Now, here's a critical detail. The uterine sound is generally not used at this stage. Why? Because there's a risk of perforation, especially if the uterus is potentially fragile. Dilatation itself is done gradually, using graduated metal dilators, increasing the size slowly. Once you have enough access, the products of conception are removed using ovum forceps. And this is followed by a gentle scraping, or curettage, using a specific type of curette, a flushing blunt curette. This final scraping confirms the cavity's clear and helps stimulate the uterus to contract.
And you mentioned controlling bleeding. There's a specific pharmacological step during the procedure itself.
Absolutely vital, yes. An injection of methergine, 0.2 milligrams, is given intravenously during the procedure. Not before, not after, but during. This is the immediate countermeasure against one of the major acute risks, which is postpartum hemorrhage, due to uterine atony, or the uterus not contracting properly. Its immediate action helps the uterus clamp down and minimize blood loss right away.
Okay, that's the one stage. Now, the two-stage operation deliberately introduces a delay. When is this slower, more deliberate approach necessary?
The two-stage procedure is really reserved for what the sources call an unfavorable cervix. What does that mean? It means the cervix is long, firm, tightly closed. Trying to rapidly, forcefully dilate a cervix like that, well, it risks severe damage, bad tears. This happens commonly in procedures like induction of a first trimester abortion, maybe a missed abortion where the uterus is still relatively small, or managing a hydatidiform mole before expulsion starts. The two-stage approach prevents that trauma.
So how is this first phase, this slow dilation, achieved mechanically? What's used?
The key here is hygroscopic action, things that absorb water and swell. So physical dilators like laminaria tents, which are made from seaweed, or Lamiscel, which is a synthetic magnesium sulfate sponge, are introduced into the cervical canal. They absorb moisture from the cervical tissues and slowly, gently expand over several hours, gradually widening the opening, the ossus. Alternatively, sometimes intravaginal misoprostol is used. That's 400 micrograms of prostaglandin E1. It's given about 3 hours before the procedure to help soften and prime the cervix chemically.
And what about safety during this waiting period? Any precautions?
Yes, definitely. Prophylactic antibiotics are usually prescribed during this slow dilatation phase, typically something like doxycycline and metronidazole. This is to manage the infection risk introduced by either the physical dilator, which is a foreign body, or potentially by the misoprostol altering the vaginal environment.
Okay, then the second phase happens, usually about 12 hours later. This involves the final, more rapid dilatation up to a specific size. The sources say 10-13 to 12-15, using the dilator sizing, followed by the actual evacuation and curettage.
Exactly. And this is where we really need to focus on the inherent dangers and late complications of D&E. It's crucial to understand these. Remember, we're dealing with a highly vascular organ. It's muscle-bound. The immediate risks can be severe. We're talking excessive hemorrhage, either from leaving some products behind or the uterus just failing to contract properly, uterine atony. And significant injury is possible, like cervical lacerations. Sometimes these tears can extend quite deeply, even causing a broad ligament hematoma, which is bleeding into the space beside the uterus.
And the risk of shock is mentioned too.
Yes, and shock can be complex here. It's not just from blood loss or anesthetic complications, though those are risks. The sources specifically mention cervical shock. This is a severe vasovagal reaction, a kind of fainting, resulting from too much stimulation of the cervix. It needs immediate resuscitation. Other immediate concerns include sepsis, infection spreading, hematometria, which is trapped blood inside the uterus, and of course, procedural failure. There's about a 1% risk that the pregnancy might continue.
And looking longer term, the layered complications, These are really critical factors when counseling a patient beforehand.
Absolutely. These can have long-lasting impacts. We're talking about things like chronic pelvic inflammation, potential infertility, cervical incompetence where the cervix weakens and can't hold a future pregnancy, leading to preterm labor, and also uterine synechia, which are adhesions or scar tissue inside the uterus, also known as Asherman syndrome. These complications themselves can increase the risk of problems in future pregnancies, like ectopic pregnancy.
Let's really focus in on one of the most serious immediate events you mentioned, the management of uterine perforation. The protocol described sounds like a masterclass in risk triage.
It really is. It's a decision tree with absolutely no margin for error. The first rule, the absolute first rule, is the procedure stops immediately. What happens next depends entirely on the size of the instrument that caused the injury. That's the key differentiator.
Okay, so if it's a small instrument, maybe like a uterine sound or one of the smaller dilators, what's the approach then?
This is generally managed expectantly. We basically rely on the uterus's natural muscular ability to contract and heal itself. We observe the patient very closely. Pulse, blood pressure, mandatory systemic antibiotics are given to prevent infection. We're watching carefully for any signs of internal bleeding or peritonitis.
But what if the injury involves a larger instrument? A bigger dilator, maybe the ovum forceps, or even a suction cannula? That suggests a pretty significant defect.
Right. That situation requires immediate, much more aggressive intervention. Diagnostic laparoscopy becomes necessary. You have to look inside the abdomen to assess the injury's size, its exact location, and crucially, the extent of any bleeding. This often transitions directly into an operative laparoscopy or even a full laparotomy open abdominal surgery to repair the defect. And a critical part of that inspection must include checking the nearby structures, especially the intestine and the omentum, because injury to those is a major risk with a large perforation.
Okay, and the most complex scenario, what if the perforation happens before the evacuation procedure is actually finished?
The evacuation still has to be stopped immediately. Then you have a few options, depending on the situation. You might be able to complete the evacuation vaginally, but only under direct laparoscopic visualization to ensure you're not causing more damage. Or you might need to perform a hysterotomy, basically a small Caesarean incision, to empty the uterus from above, especially if preserving the uterus is critical for future fertility. Or, in some cases, particularly if the patient has completed her family or the damage is severe, the safest option might be a hysterectomy, removing the uterus entirely. In all these severe perforation cases, resuscitation for shock and broad-spectrum antibiotics are absolutely mandatory.
Wow, that detailed protocol really highlights the importance of immediate, precise judgment calls. Okay, let's shift focus slightly to suction evacuation, or S&E. How does using a vacuum change the risk profile compared to the mechanical scraping of D&E?
Right. Suction evacuation, or S&E, uses a cannula attached to a suction apparatus to draw out the products of conception. While the indications overlap quite a bit with D and EMTP in the first trimester, inevitable or incomplete abortion, hydatidiform mole, the process itself is generally considered less traumatic to the uterine wall than sharp curettage.
And the procedure often uses lighter sedation, correct?
That's often the case, yes. Conscious sedation, maybe intravenous diazepam, combined with a paracervical block numbing the cervix locally is pretty standard. Key steps include using the uterine sound first to carefully measure the length and position of the uterine cavity, and then, importantly, dilating the cervix usually to one size less than the diameter of the suction cannula you plan to use. Why less? Because this allows the contracting muscle of the endocervix to actually grip the cannula during the procedure, which provides tactile feedback and is a kind of safety feature.
The vacuum pressure is raised significantly. The sources say 400 to 600 millimeters of mercury. But the real mastery here seems to be knowing exactly when to stop. What are these 4 signals of success, the endpoints for suction?
This is absolutely where the operator's senses and experience come into play. These 4 signals are the definitive feedback loops that tell you you're done. 1. No more material tissue or fluid is seen being suctioned out through the tubing. 2. You feel a distinct gripping of the cannula by the uterus as it contracts down and becomes smaller. 3. You feel a characteristic grating sensation transmitted through the cannula as its tip lightly touches the now empty, rougher uterine wall, the myometrium. And 4, you see the visible appearance of bubbles in the cannula or the clear tubing, which signifies that air, not tissue, is being pulled through. The cavity is essentially empty.
That grating sensation sounds like the most definitive feedback, confirming an empty cavity without causing damage.
Exactly. It confirms completion without needing to scrape excessively or risk over-traumatizing the tissue. And crucially, just before withdrawing the cannula, the vacuum must be broken, usually via a valve on the instrument. This prevents suction trauma to the internal os of the cervix as you pull it out. The sources also really emphasize that using ultrasonography, or USG, during the S&E procedure is becoming increasingly standard practice. It helps visualize the process, shortens the operative time, and significantly reduces the chance of leaving any tissue behind, which lowers complication rates.
Okay, great. Finally, let's quickly touch on the less invasive related procedures mentioned. Menstrual regulation and vacuum aspiration.
Right. Menstrual regulation, or MR, is specifically aspiration of the endometrial cavity within just 14 days of a missed period, so very early. It's typically done as an outpatient or office procedure, often using a simple Carmen's cannula and a 50-milliliter syringe to create manual suction. The absolute defining feature here, the critical requirement, is examining the aspirated tissue immediately for placental villi. If villi are absent, you have to strongly suspect a failed procedure, a molar pregnancy, or potentially a dangerous ectopic pregnancy. This requires immediate follow-up, usually with blood tests for human chorionic gonadotropin, or HCG levels, and a transvaginal ultrasound.
Got it. And vacuum aspiration, which includes both manual vacuum aspiration, MVA, and electric vacuum aspiration, EVA. This sounds highly effective.
Yes, it's considered highly effective. The source is, quote, 98 to 100% effectiveness for MTP, up to 12 weeks of gestation. MVA uses a hand-operated double-valve plastic syringe, usually 60 milliliters, attached to a Carmen's cannula of appropriate size, up to 12 millimeters. It creates a strong negative pressure, around 660 millimeters of mercury. It's generally less traumatic than mechanical D&E and typically much faster, often taking only 5 to 15 minutes to complete.
Okay, moving on now to a procedure that involves a full abdominal incision, hysterotomy. As defined, this is extracting the products of conception before viability, specifically before the 28th week, by actually cutting into the anterior uterine wall through the abdomen. The sources note it's rarely done today just for MTP, but the specific indications for it remain important to know.
That's right. Hysterotomy is really reserved for situations where the standard vaginal evacuation methods are either impossible or considered too risky. So indications would include things like a mid-trimester MTP, where prostaglandin methods have failed or are contraindicated for some reason. Also, if large fibroids are physically obstructing access to the uterine cavity from below, or if the patient has a completely low-lying placenta, a placenta previa, making vaginal evacuation dangerous, or sometimes certain uterine anomalies might necessitate it. It's also considered for women who've had multiple previous cesarean deliveries because they have a much higher risk of the placenta growing into the old scar tissue, what we call morbidly adherent placenta or placenta accreta.
And the surgical steps themselves mirror major abdominal surgery, right?
They absolutely do. After getting adequate anesthesia, usually general or epidural, the abdomen is opened, typically via a low transverse incision like a Fanon style or sometimes an infraumbilical vertical incision. The uterus is then often gently drawn out of the abdomen or exteriorized, and importantly, 0.2 milligrams of methergine is given intravenously before making the uterine incision. This is to stimulate the uterus to contract immediately after the contents are removed, which helps minimize blood loss right from the start.
Okay, and how is the uterine wall itself, the thick muscular tissue, actually incised?
The incision on the uterus is usually vertical, typically about 5 centimeters or 2 inches long. This vertical orientation often facilitates easier access and repair compared to a transverse cut in this context. The repair, however, that's the really critical biomechanical step here. The uterine incision must be closed meticulously in 3 distinct layers, usually using an absorbable suture like or a catgut or a synthetic like Vicryl.
3 layers. Why the complexity? Why not just a simpler closure?
This is quite deliberate. It's really an engineering solution to handle the unique properties of the uterus. Layer 1 closes the deeper myometrium, the main muscle bulk, and care is taken here is to specifically exclude the decidua, the inner lining, to prevent forming inclusion cysts later on. Layer 2 is usually a continuous suture that takes in the entire remaining thickness of the muscle, reinforcing that primary closure line. and layer 3 opposes the peritoneal flaps over the incision line. This multi-layer closure is absolutely necessary to manage the massive stretching and contraction forces the uterus undergoes. It ensures robust hemostasis, stopping bleeding, it obliterates any dead space where hematoma could form, and most importantly, it aims to create the strongest possible scar to minimize the risk of rupture in a future pregnancy.
And the complications of hysterotomy reflect its nature as major surgery, covering both immediate surgical risks and longer-term reproductive ones.
Exactly. Immediately, you face risks like significant bleeding, infection like peritonitis, potential intestinal obstruction from adhesions, and the inherent hazards of anesthesia. Remote complications, though, are also significant. Things like menstrual abnormalities can occur. There's a rare but recognized risk of scar endometriosis, where endometrial tissue grows in the scar, about a 1% risk. And critically, compared to a standard low-segment Caesarean scar, a hysterotomy scar carries a significantly higher risk of rupturing during a subsequent pregnancy or labor.
Okay, let's shift gears dramatically now, moving from a rare major surgery to arguably the most common obstetric operation performed worldwide. Episiotomy, sometimes called perineotomy, defined as a surgically planned incision on the perineum and a posterior vaginal wall made during the second stage of labor.
That's right. And technically, it is an inflicted second-degree perineal injury, but it's done with very clear objectives in mind. The goal is to deliberately enlarge the vaginal opening, the introitus, to allow for a safer delivery, particularly when instruments are needed. And importantly, it aims to substitute a clean, controlled surgical incision for what might otherwise be an uncontrolled, jagged, spontaneous rupture. Those kinds of tears can cause devastating damage to the perineal body, the muscles, and the fascia, potentially involving the rectum.
Now, the sources really emphasize that this should only be done for selective cases, not just routinely for everyone. What are the clear indications that would trigger performing an episiotomy?
Good point. Routine use is discouraged. The specific indications include situations like a very rigid perineum, which might be seen in older first-time mothers, what we used to call elderly prima gravidae, or if you anticipate a severe tear is likely anyway, maybe because of a very big baby, or a difficult presentation like face to pubis, or a breech delivery, or in cases of shoulder dystocia. And critically, it's almost always indicated for any operative vaginal delivery that involves forceps or the ventouse, where you need that extra space and sometimes speed is crucial.
Timing is also key, isn't it? To minimize blood loss and maximize the effect.
Yes, absolutely. The ideal time to make the cut is immediately before crowning. That's when the perineum is visibly bulging and stretched thin. Specifically, the guideline is often when about 3 to 4 centimeters of the fetal head is visible during a contraction. At this point, the tissue is maximally stretched and relatively avascular, meaning less bleeding.
Okay, and we primarily focus on the two main types discussed, mediolateral and median. Can you outline the difference?
Sure. The mediolateral incision starts at the midpoint of the fourchette, that's the posterior junction of the labia minora, and is directed downwards and outwards away from the anus, usually at about a 45 to 60 degree angle. It typically runs about 2.5 centimeters long. Its main advantage, its merit, is safety. It offers relative protection from accidentally extending into the rectum. But its demerit is that it tends to cause greater blood loss and often more post-operative discomfort compared to the median type. The median incision, on the other hand, goes straight back posteriorly in the midline from the fourchette, also for about 2.5 centimeters. It boasts the least blood loss, it's generally the easiest to repair anatomically, and results in the most post-operative comfort. But, and this is a big but, its significant drawback is the much higher risk of uncontrolled extension posteriorly, potentially involving the anal sphincter complex or even the rectum itself. That's a serious complication.
Let's focus on the repair, specifically for the more common mediolateral episiotomy. This happens right after the placenta is delivered, correct?
Yes, repair should be done promptly after placental expulsion, under good lighting and ensuring adequate anesthesia, often using local infiltration if an epidural isn't in place. The repair must be meticulous, done under strict asepsis. It's performed in 3 distinct layers, typically using an absorbable suture material like polyglycolic acid, which is Dexin, or maybe chromic catgut. Layer 1 closes the vaginal mucosa, starting the stitching from the apex, the deepest point of the incision inside the vagina, and working downwards towards the opening. Layer 2 focuses on opposing the perineal muscles. This includes the superficial and deep transverse perineal muscles, and sometimes part of the levator ani-muscle complex. The goal here is to bring the cut muscle edges together accurately and obliterate any dead space where blood could collect. And finally, layer 3 closes the skin and subcutaneous tissues. The aim is perfect anatomical alignment and achieving hemostasis, stopping all bleeding without putting too much tension on the sutures, which could impair healing.
And the complications, both immediate and remote ones.
Immediate complications are often linked to either the incision itself or, more commonly, a faulty repair. Things like unintentional extension into the rectum, especially with median episiotomies. Vulval hematoma formation, a collection of blood under the skin, is another risk. Infection is always a concern with any wound. And sometimes wound dehiscence, where the repair breaks down. Injury to the anal sphincter can occur. And very rarely, a severe infection called necrotizing fasciitis. Remote complications which can really impact long-term quality of life include dyspareunia, which is persistent pain during sexual intercourse. Also, women who've had an episiotomy might be more prone to subsequent lacerations and future deliveries. And again, very rarely, scar endometriosis can develop in the episiotomy scar itself. Right, moving into instrumental delivery, this is definitely a high-stakes area requiring the operator to function almost like a biomechanical engineer in real time. Whether we're talking about using obstetric forceps or the Ventouse, which is the vacuum extractor, the decision to proceed is governed by really stringent prerequisites. These act as the essential patient safety firewall.
Okay, let's list those. What are the absolute required fetal and maternal criteria that must be met before even considering an instrumental delivery?
This list is non-negotiable. First, the fetal head must be engaged. Clinically, that means 1/5 or less of the head is palpable above the pelvic brim when examining the abdomen. Second, the cervix must be fully dilated, 10 centimeters, no exceptions. Attempting instrumental delivery through an incompletely dilated cervix is a recipe for disaster, causing severe tears. Third, the membranes must have ruptured. Fourth, the exact position of the fetal head must be known precisely. You need to know if it's OA, OP, OT, and the degree of rotation. And finally, the pelvis must have been assessed and deemed adequate for vaginal delivery. Trying to pull a baby through a pelvis that's too small, cephalopelvic disproportion, or CPD, is futile and dangerous. Missing any single one of these criteria just elevates the risk exponentially.
Okay, so those are the clinical state requirements. Beyond that, what other preparatory steps are absolutely mandatory?
Preparation is absolutely key. The patient's bladder must be emptied, usually with a catheter, to prevent injury and maximize pelvic space. Adequate analgesia must be in place. This is usually a working regional block like an epidural, or at minimum, a pudendal block to numb the perineum. Informed consent is mandatory, explaining the risks, benefits, and alternatives, including cesarean. Crucially, the operator must be experienced and skilled in the chosen instrument. Aseptic techniques, as we discussed earlier, must be flawless. And, very importantly, there must be a predetermined, immediately available backup plan for failure. This almost always means being ready to proceed directly to a cesarean section if the instrumental delivery doesn't progress safely.
And that brings us to what seems like the ultimate hallmark of professional judgment in this situation: the willingness to abandon the procedure if it's not working.
Exactly. That's spot on. An instrumental delivery is essentially a trial of labor, a trial of forceps, a trial of Ventouse. If significant difficulty is encountered, if there's no descent with reasonable traction, the procedure stops immediately. The decision to abandon the attempt and shift to a cesarean section is not a failure. It's the measure of safe, sound clinical practice.
Okay, let's delve into the obstetric forceps first. They seem to serve multiple functions beyond just pulling, right?
Yes, they do more than just traction. They provide traction, of course. The sources mention needing about 20 kilograms of pull force in a first-time mother, a prima gravida, and maybe around 13 kilograms in a multipara, someone who's delivered before. They can also facilitate rotation of the fetal head, especially using specialized types like Kielland's forceps for transverse or posterior positions. In some situations, like with premature babies, they can act as a protective cage, guiding the fragile head gently, and they're used for controlled delivery of the aftercoming head during an assisted breech delivery. They allow minimal compression, but only when applied correctly over the biparietal diameter of the head.
Let's zoom in on the biomechanical design you mentioned, particularly of the long curved forceps like the DUTTA's variety you mentioned. The specific dimensions sound critical.
Oh, they absolutely are. This is where the engineering aspect really comes into play. The standard long curved forceps, like DUTTA's, are typically around 37 centimeters long overall. They possess two essential distinct curves. First, there's the pelvic curve. This has a fairly large radius, about 17.5 centimeters according to the source material. It's designed to align perfectly with the natural curve of the mother's birth canal, the axis of the pelvis. Second, there's the cephalic curve. This has a smaller radius, around 11.5 centimeters. It's specifically shaped to gently cradle and grasp the fetal head along its sides across the biparietal diameter without causing undue compression, but again, only if the application is perfect.
And the other main types mentioned, short-curved and Kiellands.
Right. The short-curved forceps, like Wrigley's, are shorter and have less pronounced curves. They're used pretty much exclusively for outlet forceps operations when the head is right down on the pelvic floor and minimal traction is needed. Kielland's forceps are quite unique. They are long, nearly straight, with only a very slight pelvic curve, and crucially, they feature a sliding lock mechanism. This design is specifically for correcting asynclitism, that's when the baby's head is tilted to one side, and for rotating the head, particularly from transverse or posterior positions, safely within the pelvis.
Okay. And the American College of Obstetricians and Gynecologists, ACOG, has a strict classification for these operations based on the fetal head station and rotation.
Yes, and this classification is really a crucial safety standard. It defines what's appropriate. Outlet forceps is the easiest type. The baby's scalp is visible at the opening without separating the labia, the head is right on the pelvic floor, and the sagittal suture is in an anterior-posterior diameter or maybe rotated less than 45 degrees. Low forceps constitutes the vast majority of forceps deliveries, maybe 90%. Here, the leading bony point of the skull is at station plus 2 centimeters or lower, but not yet right on the pelvic floor. Rotation can be more than 45 degrees here, too.
And mid-forceps, that sounds more challenging.
It is. Mid-forceps makes up maybe the remaining 10% of cases. This is when the head is engaged, meaning the widest part is past the pelvic inlet, but the leading point is still above station plus 2 centimeters. The head must not be above the level of the ischial spines, though. And critically, as you noted, high forceps, where the head is not even engaged, is explicitly not included in the modern classification. It's considered obsolete and dangerous and should not be attempted.
The success and safety of forceps seem to hinge entirely on this concept of application principle. Specifically, the difference between cephalic and pelvic application. Can you explain that?
This is probably the single most important principle for safe forceps use. Cephalic application is non-negotiable. It's the goal. This means the blades are applied precisely along the sides of the baby's head, grasping the biparietal diameter, the distance between the two parietal bones. This ensures the pressure is distributed evenly and safely over the strongest part of the skull. Pelvic application, on the other hand, is where the operator ignores the head's position and simply applies the blades along the sides of the mother's pelvis. This must be avoided at all costs. Why? Because it risks applying force incorrectly, potentially causing serious localized compression injury to the fetal cranium or face.
Okay, so cephalic application is the standard. Once the forceps are applied correctly, the traction itself needs to follow a very precise geometry, doesn't it?
Absolutely. The traction should be steady but intermittent, meaning you pull only during a contraction and relax between contractions, mimicking natural labor. The direction of the pull is really an art, and it must follow the curved axis of the birth canal precisely. You start pulling generally downwards and backwards towards the floor. As the head descends, the direction shifts to become more horizontal, straight backwards. And finally, as the head begins to crown and extend under the pubic bone, the direction of pull shifts upwards and forwards towards the ceiling, facilitating extension and delivery over the perineum. Following this J-curve minimizes maternal trauma.
And if the procedure runs into difficulties, if the baby isn't descending, what defines the failure point where you have to stop?
Difficulties often arise from an initial faulty assessment. Maybe the cervix wasn't fully dilated after all, the head wasn't rotated as thought, or there's unsuspected cephalopelvic disproportion. The absolute rule, the critical safety point, is this. If moderate traction fails to overcome the resistance and achieve clear, progressive descent of the fetal head down the birth canal, the procedure is deemed a failure. At that point, it must be immediately abandoned in favor of a Caesarean section. Persisting with forceful or sustained high-traction pulling is the primary cause of severe fetal injuries, like intracranial hemorrhage or nerve damage.
Let's quickly touch on the potential consequences if things go wrong, either through failure or injury.
Right. Maternal complications can be significant. Severe tears of the vagina, cervix, or perineum, sometimes extending to the rectum, 3rd or 4th degree tears. Postpartum hemorrhage is a risk due to potential tears or uterine atony. Nerve injury is also possible, things like temporary or permanent damage to the femoral nerve or the lumbosacral trunk, especially with difficult mid-forceps deliveries causing pressure within the pelvis. Anesthetic issues are also a concern. For the fetus, immediate complications include asphyxia, lack of oxygen. Visible injuries like facial bruising or marks from the blades are common but usually minor. More serious risks include cephalohematoma, which is bleeding under the scalp periosteum, facial nerve palsy, causing temporary facial weakness, and the most feared complication, intracranial hemorrhage or brain injury.
Okay, let's switch gears now to the Ventouse, or the vacuum extractor. This assists delivery using negative pressure to essentially drag the cranium.
Right. The mechanism here is fundamentally different from forceps. It uses a suction cup applied to the baby's scalp. Modern devices often use soft cups made of silastic material or sometimes a rigid plastic cup like the Kiwi Omni cup, which has gained popularity. These are generally preferred over the older metal cups due to a lower risk of scalp injury. The cup is attached via tubing to a vacuum generator. The placement of the cup is critical for success. The largest possible cup that fits should be selected. It should be placed directly against the fetal scalp, ideally positioned near the occiput, the back of the head. Specifically, the ideal spot is over the flexion point, or pivot point, which is located on the sagittal suture about 6 centimeters back from the anterior fontanelle, the front soft spot. Placing it here helps maximize flexion of the baby's head during traction, which presents the smallest diameter to the pelvis.
Okay, placement is key. And the vacuum generation itself, how is that managed?
The negative pressure is raised slowly, typically over about 10 minutes, not instantly. This allows a proper seal, or chignon, to form under the cup. The effective vacuum level needed is usually around 0.8 kilograms per square centimeter, which translates to about 608 millimeters of mercury negative pressure. Traction must be applied correctly, at a right angle to the plane of the cuff, and again, only synchronous with maternal contractions and effort. And just like with forceps, there's a critical abandonment rule here. If there is absolutely no descent of the head after 3 consecutive pulls with good application and effective vacuum during contractions, the procedure should be stopped and you must transition to Caesarean section.
What advantages does the Ventouse generally offer compared to forceps?
Well, the Ventouse tends to be less space occupying within the vagina, which can be helpful. It generally requires less maternal analgesia than forceps might. A key advantage is that it can often be used successfully even when the head is unrotated or malrotated, as it can facilitate autorotation of the head as it descends. And importantly, studies generally show that the Ventouse causes lower rates of significant maternal trauma, particularly severe genital tract lacerations and pelvic floor injuries, compared to forceps. It's also often considered comparatively easier for trainees to learn the basic technique.
But it's not without its own significant disadvantages, particularly regarding speed and fetal safety concerns.
Exactly. It's generally a slower procedure than forceps, which makes it unsuitable for situations requiring very rapid delivery due to acute fetal distress. It is strictly contraindicated in preterm fetuses, generally those less than 34 weeks gestation, because their craniums are too fragile and the scalp is easily damaged. It's also often avoided in cases of suspected macrosomia, a very large baby. The major disadvantage and the main trade-off compared to forceps is that the Ventouse causes significantly more neonatal scalp trauma. This ranges from common, usually benign cephalomatomas to the more serious and potentially dangerous subaponeurotic hemorrhage, which is bleeding into the loose space under the entire scalp. The failure rate is also generally higher than with forceps.
And a final important warning from the sources regarding instrumental delivery. The sequential use of first trying the Ventouse and then switching to forceps if it fails, or vice versa. That's strongly discouraged, right?
Yes, that practice, sometimes called sequential instrumentation, significantly increases the risk of trauma to both the mother and the neonate compared to using just one instrument successfully or proceeding directly to CS after a failed first attempt. The evidence strongly suggests the operator should carefully select the most appropriate instrument for the specific clinical situation, give it a fair, controlled trial following all the prerequisites and safety rules, and if that chosen instrument fails, the only safe recourse is usually a Caesarean section. Avoid combining the risks.
Okay, let's discuss version next. This is defined as a manipulative procedure, specifically designed to change the fetal lie of the baby's orientation in the uterus to bring a more favorable pull, usually the head, down to the lower pole of the uterus, engaging the pelvis. We have several types mentioned: spontaneous, external, internal, and bipolar.
Right. But external cephalic version, or ECV, is really the primary focus in modern obstetric practice today. ECV is a maneuver done solely by manipulating the fetus through the mother's abdominal wall externally, aiming to turn a breech, bottom down, or transverse sideways baby to a cephalic head-down presentation. It's usually attempted after 36 weeks of gestation, sometimes a bit earlier or later.
The success rate is quoted around 60%, and it can be increased by using tocolytic drugs like rutadrine or turbuline to relax the uterus first. What defines the actual maneuver itself? How is it done?
It typically uses what's called the forward roll technique, although a backward roll is sometimes tried if the forward roll fails. Essentially, the operator uses both hands on the mother's abdomen. One hand tries to gently lift the breech out of the pelvis, while the other hand applies pressure to the head, encouraging the baby to perform a slow somersault inside the uterus. You're mobilizing the breech towards one side, the iliac fossa, and pushing the poles in opposite directions. It requires skill and patience. And the critical post-procedure requirement is continuous fetal heart rate, or FHR, monitoring for a period afterward, usually with a CTG trace, to check for any signs of fetal distress or placental abruption, which are potential risks. And of course, as with any potentially sensitizing event in pregnancy, Rh-negative women who undergo ECV require an injection of anti-D gamma globulin afterward to prevent isoimmunization.
Okay, that's ECV. Now, internal version sounds far riskier and is rarely used today, according to the sources.
That's absolutely correct. Internal version involves the operator inserting a hand inside the uterus to grasp a part of the fetus, usually a foot, to turn it. It's almost always a pedalic version, turning the baby to a breech presentation by bringing a foot down, and it's typically completed with immediate extraction of the fetus, a breech extraction. Its current indication is extremely limited. The main one cited is managing a persistent transverse lie in the second baby of twins after the first twin has delivered vaginally. The conditions for attempting it are absolute. The cervix must be fully dilated, there must be adequate amniotic fluid remaining, and the fetus must be alive and viable.
Given its very limited use now, the complications must be severe.
They are indeed high stakes for both mother and baby. Maternal risks include placental abruption, tearing away of the placenta, and potentially rupture of the uterus itself due to the internal manipulation. Fetal risks are catastrophic. Perinatal mortality rates historically associated with internal version were extremely high, approaching 50% in some series, primarily due to birth asphyxia from cord compression or prolapse during the extraction, and birth trauma. It's a procedure largely relegated to history or very specific, rare circumstances now.
Now we have to turn to a difficult topic: destructive operations. The sources are quite unequivocal that these procedures, which are designed to diminish the bulk of the fetus to allow for delivery, really represent a failure of modern obstetric care. They have virtually no place in well-organized health sectors today and are mostly seen in settings with neglected or obstructed labor.
Yes, it's crucial to understand these procedures primarily for historical context, and unfortunately because they are still sometimes required in resource-poor settings where access to safe Caesarean section is limited or delayed. But they are procedures of last resort on a dead or non-viable fetus, or occasionally a fetus with a severe anomaly incompatible with life. Craniotomy is probably the most commonly known. This involves perforating the fetal head to allow its contents, the brain matter, to be evacuated, thus reducing the size of the head. The main indication historically, and in settings where it's still used, is for obstructed labor with a confirmed dead fetus in a cephalic presentation, where the head is impacted in the pelvis, or sometimes to manage severe hydrocephalus, even if the fetus is technically living, if vaginal delivery is otherwise impossible and Caesarean section poses extreme maternal risk.
The procedure itself involves specialized and frankly quite gruesome-sounding instruments.
It does. Perforation is typically achieved using an instrument like Oldham's perforator, or sometimes even sharp-pointed Mayo scissors in extremis. The perforation is usually made through one of the parietal bones, avoiding the sutures and fontanelles. The brain matter is then broken up or churned, and extraction of the collapsed head is then achieved using other instruments like a cranioclast, which grasps the skull bones, or sometimes a giant valcellum forceps.
And the other destructive procedures mentioned: decapitation, evisceration, and cleidotomy. Can you briefly explain those?
Sure. Decapitation is literally severing the fetal head from the trunk. Its main indication is a neglected shoulder presentation with a dead fetus, where the neck is accessible vaginally. It allows the body to be delivered first, followed by the head, or, very rarely, in the case of locked twins, evisceration involves removing the thoracic and abdominal contents piecemeal through an incision in the fetal chest or abdomen. This might be indicated in a neglected shoulder presentation if the neck isn't accessible, or sometimes for severe fetal malformations causing gross abdominal distension like severe ascites. And cleidotomy is the division of one or both clavicles, the collarbones. This is done specifically to reduce the bulk of the shoulder girdle, indicated only in cases of shoulder dystocia with a confirmed dead fetus, excluding anencephaly, where shoulders are often not the issue.
After any of these destructive procedures, the postoperative care must be mandatory and intense due to the high risk of severe maternal trauma.
Absolutely. Mandatory meticulous exploration of the entire uterovaginal canal, uterus, cervix, vagina is required immediately afterward to check for any tears, lacerations, or even uterine rupture caused by the instruments or manipulations. A Foley's catheter is usually placed in the bladder and left in for several days, maybe 3 to 5 days, especially after craniotomy, to ensure adequate drainage and monitor for potential bladder injury. Aggressive resuscitation for potential shock and hemorrhage is often needed. And systemic intravenous antibiotics, with the sources specifically mentioning ceftriaxone, are necessary given the extremely high risk of severe pelvic infection following these procedures. Okay, so now we arrive at the Caesarean section, or CS, defined simply as an operative procedure to deliver a fetus, or fetuses, after the stage of viability, conventionally 28 weeks in these sources, though often earlier now, through incisions made in the abdominal wall and the uterine wall. It excludes deliveries following a uterine rupture. Its history is fascinating, tracing back possibly to the Roman Lex Caesarea law, which supposedly mandated attempting abdominal delivery on a dying woman to save the baby. But the modern safe procedure really took off with the popularization of the lower segment operation, largely credited to Monroe Kerr around 1926.
And the incidence, the rate of cesarean sections is steadily rising across the globe. What are the key drivers behind this significant trend?
It's multifactorial. A major factor is undoubtedly the increased safety of the procedure itself, thanks to advances in anesthesia, surgical techniques, antibiotics, and blood transfusion services. CS is much safer for the mother than it was decades ago. But we also see wider utilization of repeat CS for women who've had one before. There's been a decline in the rates of attempted operative vaginal delivery, forceps, ventouse, and vaginal breech delivery. Increased average maternal age at childbirth plays a role. The widespread use of continuous electronic fetal monitoring, or EFM, during labor arguably leads to more interventions for perceived fetal distress. And increasingly, we see cesarean sections performed simply upon maternal request, even without a strict medical indication.
It's important to strictly differentiate the absolute indications from the much more common relative ones. What constitutes an absolute need for CS?
Absolute indications mean that vaginal delivery is physically impossible or poses an unacceptably high, life-threatening risk to the mother, even if the fetus has died. These situations are relatively rare, but include things like a central placenta previa, where the placenta completely covers the cervix, or a severely contracted pelvis representing absolute cephalopelvic disproportion, CPD, or if there's a large pelvic mass, like a fibroid or ovarian tumor, physically obstructing the birth canal, or advanced carcinoma of the cervix, or some forms of vaginal obstruction, like severe scarring from previous surgery or trauma.
Okay, those are the absolute. The relative indications are far more common in practice, aren't they?
Yes, much more common. These are situations where vaginal delivery might be possible, but it's considered unduly risky for either the mother or the fetus, or both, compared to a planned or emergency CS. Examples are numerous. Relative CPD, where there's a suspected mismatch but not absolute obstruction. Previous cesarean delivery, especially if the reason for the first CS is likely recurrent, or if the woman has had 2 or more prior CS. Non-reassuring fetal heart rate patterns on monitoring, often termed fetal distress. Malpresentations that persist, like breech or transverse lie where vaginal delivery is riskier or not possible. Antepartum hemorrhage from conditions like placenta previa, even if not central, or placental abruption. And various maternal medical disorders where the stress of labor is best avoided, like certain heart conditions.
And the timing of an emergency CS is quite strictly categorized by guidelines, like those from the National Institute for Health and Care Excellence, NC, in the UK.
Yes, these categories help prioritize urgency and resource allocation. Category 1 is defined as an immediate threat to the life of the woman or fetus. The target decision to delivery interval, or DDI, should be 30 minutes or less. Think cord prolapse or severe placental abruption. Category 2 indicates maternal or fetal compromise, but it's not immediately life-threatening. Delivery is required urgently, typically targeting within 75 minutes. Examples might be prolonged deceleration on the FHR trace. Category 3 needs early delivery, but there's no current maternal or fetal compromise. The delivery should be timely, but it's not an immediate rush. Maybe failure to progress in labor over several hours. And Category 4 is the elective or planned cesarean section, where the delivery time is planned to suit the woman and the staff.
Okay. The lower segment cesarean section, or LSCS, is overwhelmingly the standard practice today. The preoperative preparation described is really a testament to modern safety protocols, designed specifically to combat major risks like anesthetic aspiration and infection.
Absolutely. This preparatory checklist is critically important for patient safety, especially before emergency CS. It includes obtaining written informed consent, mandatory Foley catheterization to keep the bladder empty and out of the surgical field, and, very importantly, a complex anti-aspiration cocktail is given, specifically designed to neutralize stomach acid and reduce the volume of stomach contents, minimizing lung damage if aspiration occurs during anesthesia induction.
Let's just detail that anti-aspiration cocktail again, as it's quite specific.
Sure. The patient typically receives a non-particulate antacid, often 0.3 molar sodium citrate, given orally shortly before surgery. This rapidly increases gastric pH. They also usually receive an H2 blocker, like ranitidine or famotidine, intravenously or orally sometime beforehand to reduce acid production, and often metoclopramide, 10 milligrams intravenously, which helps increase the tone of the lower esophageal sphincter and speeds gastric emptying. The combination minimizes the risk and severity of aspiration pneumonitis, also known as Mendelssohn syndrome.
And there's that critical positioning detail as well.
Yes, the patient must be positioned on the operating table with a 15-degree left lateral tilt. This can be achieved using a wedge under the right hip. This is non-negotiable. It physically displaces the heavy gravid uterus off the inferior vena cava and the aorta, preventing aortocaval compression, which can cause severe maternal hypotension and reduce blood flow to the fetus. And finally, prophylactic intravenous antibiotics, usually a single dose of broad-spectrum cephalosporin, must be given ideally about 1 hour prior to the skin incision to reduce the risk of postoperative infections significantly.
Okay, preparation is meticulous. Regarding the incision itself, the surgeon usually opens the abdomen via a transverse, or modified Pfannenstiel, incision made about 3 centimeters above the pubic symphysis.
Yes, this transverse abdominal incision is generally preferred for cosmetic reasons and often results in better postoperative comfort and less pain compared to a vertical midline incision. It does take slightly longer to perform, though. However, the truly crucial difference lies in the uterine incision. The standard today, used in over 90% of cases, is the low transverse incision made in the lower uterine segment. This choice is driven by the anatomical advantages of this part of the uterus during pregnancy.
How is that low transverse uterine incision actually performed?
After identifying the lower segment, which is thinner and less muscular than the upper segment, a small transverse incision, maybe 2 to 3 centimeters, is made carefully in the midline with the scalpel, avoiding the bladder below. Then, the mitral fibers of the lower segment are bluntly split or stretched transversely, often using the operator's 2 index fingers pulling outwards, or sometimes using bandage scissors. This blunt dissection across the fibers minimizes bleeding compared to a sharp cut. Why is this incision so heavily favored? Well, it's generally easier to repair. It involves less dissection of the bladder off the uterus. And most importantly, the resulting scar is located in the non-contractile part of the uterus, making it significantly stronger. This leads to a much lower risk of scar rupture in a future pregnancy or labor. The sources quote only 0.5 to 1.0% risk. Once the uterine incision is complete and the amniotic sac is ruptured, the delivery of the baby needs to be swift. The optimum interval between making the uterine incision and delivering the baby should ideally be less than 90 seconds to minimize the risk of fetal hypoxia.
The delivery is usually completed by the surgeon slipping a hand beneath the baby's head, elevating and flexing it out through the incision, often with an assistant, providing gentle pressure on the uterine fundus from above. Then oxytocin, or methergine, is given right after the shoulders are delivered to help the uterus contract. How is the placenta typically managed?
The placenta is usually delivered by controlled cord traction, similar to a vaginal delivery, waiting for signs of separation, and then gently pulling on the cord while guarding the uterus. Routine manual removal of the placenta, just reaching in and pulling it out immediately after the baby, is generally avoided nowadays unless there's excessive bleeding or difficulty with spontaneous separation. Manual removal is known to increase the risk of hemorrhage and postoperative endometritis, or uterine infection.
And we return again to the biomechanics of the closure. The uterine wound, that low transverse incision, must be sutured carefully, typically in multiple layers. The sources specify 3 layers.
Yes, the 3-layer closure is often described as standard, although variations exist, like 2-layer closures, typically using an absorbable suture like xerochromic catgut or synthetic like Vicryl. The layers aim to reapproximate the muscle effectively and ensure hemostasis. The first layer usually closes the deeper part of the myometrium. The second layer might imbricate or overlap the first, taking in the more superficial muscle. And the third layer sometimes refers to closing the visceral peritoneum over the incision line, although non-closure of both the visceral and parietal peritoneum is increasingly common practice now and may reduce adhesion formation. The goal is a strong, well-healed scar.
Okay, contrast this standard LSCS now with the classical Caesarean section. This sounds very different.
It is quite different. The classical approach involves a longitudinal or vertical incision made much higher up on the uterus in the midline of the anterior wall of the upper contractile segment, starting below the fundus and extending downwards for maybe 12.5 centimeters or 5 inches. Its indications today are very limited. It might be necessary if there are dense adhesions obliterating access to the lower segment, perhaps from previous surgeries, or if there's a large fibroid located low down, physically preventing a lower segment incision, or sometimes in cases of invasive cervical cancer or certain transverse lies where the baby's back is down, or in very rare situations like a perimortem cesarean delivery where speed is the absolute priority. The major drawback is the scar. The upper segment of the uterus is thick, muscular, and actively contracts during labor. A scar in this area is inherently weaker and under much more tension during healing and in subsequent pregnancies. Consequently, the risk of future scar rupture, often catastrophic rupture before labor even starts, is significantly higher. The sources quote figures ranging from 4 to 9%. This dramatic difference in safety is precisely why the LSCS became the non-negotiable standard for almost all cesarean deliveries.
Finally, let's just list the major maternal complications associated with Caesarean section in general.
Sure. Intraoperative complications include things like unintentional extension of the uterine incision downwards toward the cervix or laterally into the broad ligament where the major uterine vessels run, potentially causing severe hemorrhage or hematoma formation. Injury to the bladder is a known risk, especially if adhesions are present. It requires meticulous two-layer closure if it occurs. Ureteral injury is rare but serious. Hemorrhage, of course, is always a risk. And dealing with a morbidly adherent placenta, like accreta, can be extremely challenging and often necessitates a cesarean hysterectomy. Immediate postoperative complications include postpartum hemorrhage, either from uterine atony or retained products, shock from blood loss, dehydration, or sometimes ketoacidosis in diabetics. Anesthetic hazards remain a concern, particularly aspiration pneumonitis, Mendelssohn syndrome if precautions fail. Infections are common risks, including endomyometritis, infection of the uterine lining and muscle, urinary tract infections, UTIs, and wound infections. Intestinal obstruction, usually due to paralytic ileus in the first few days, can occur. And deep vein thrombosis, or DVT, blood clots in the legs, is a significant risk after any major surgery, including CS.
And the management for those really catastrophic complications you mentioned.
Cesarean hysterectomy. The surgical removal of the uterus immediately following the cesarean delivery is sometimes the only life-saving measure. It's indicated primarily for uncontrollable, life-threatening postpartum hemorrhage, often due to uterine atony unresponsive to all medications, or in cases of morbidly adherent placenta accreta, increta or precreta, where the placenta cannot be safely separated. It might also be necessary for extensive uterine lacerations or uterine rupture that cannot be repaired.
Okay, we conclude our deep dive today with two quite different procedures focused either on expanding the birth canal itself or on providing innovative assistance. Symphysiotomy and the BD Odon device. Let's start with symphysiotomy. This is defined as an operation to actually enlarge the pelvic capacity by surgically dividing the symphysis pubis joint at the front of the pelvis.
Yes, and this procedure exists within a very specific and increasingly rare context. It's primarily considered as an alternative to a potentially risky cesarean section, particularly in resource-limited settings, for carefully selected cases of obstructed labor. Its main theoretical advantage is that it provides a permanent enlargement of the pelvic dimensions. The conditions for considering it are very strict. The pelvis must not be severely contracted overall. It's most suited for cases of isolated outlet contraction, where the main restriction is at the bottom of the pelvis. The presentation must be vertex, head down. And crucially, the fetal heart rate must be present and reassuring. It's not typically performed on a dead fetus.
And the procedure itself involves a precise division of the pubic joint.
That's right. Under local anesthesia, the fibrocartilage of the symphysis pubis is divided strictly in the midline, usually using a special guarded knife, until the underlying arcuate ligament is also cut. allowing the pelvic bones to separate slightly, maybe by 2 to 3 centimeters. Delivery is then usually completed with instrumental assistance, with the ventouse generally being preferred over forceps after some episiotomy. Complications can include significant retropubic pain, potential infection like osteitis pubis, and sometimes long-term issues like stress, urinary incontinence, or pelvic instability. It's a procedure with limited applicability in modern obstetrics where safe CS is available.
Okay, now let's look at something much more recent and innovative. The BD-Odon device. Its purpose, as described, is to assist operative vaginal delivery, but using significantly less force compared to traditional methods like forceps or vacuum.
Yes, this is a really interesting and potentially promising innovation developed based on an idea by an Argentinian car mechanic, Jorge Odon. The device itself consists of an inflatable circular air cuff, a bit like a small donut, which is attached to a thin but strong polyethylene sleeve. This assembly is introduced into the birth canal using a semi-rigid plastic applicator, guiding it gently around the baby's head beyond its widest diameter.
And how does its mechanism actually compare to forceps or vacuum?
It's quite different. Once positioned correctly around the head, the air cuff is inflated, but the pressure used is relatively low. The sources mention 40 to 80 kilopascals, kPa, which is much lower than the negative pressure generated by a vacuum extractor. The cuff aims to create a gentle, encompassing grip around the head, ideally sited near the C7 vertebra area posteriorly, providing a stable anchor point. Traction is then applied manually to the polyethylene sleeve, synchronous with maternal contractions and pushing efforts to gently ease the baby out. The hypothesized and in early studies observed benefits are potentially substantial. It seems to exert considerably less direct force on the fetal head compared to forceps, potentially reducing complications like bruising, facial nerve injury, or skull fractures. It also avoids the suction effect of the vacuum, possibly reducing the risk of cephalometoma or scalp lacerations, and it doesn't appear to cause the same degree of perineal distension as forceps can. Early safety studies suggest it's likely to be at least as safe as forceps and ventouse, and it appears usable across various common head positions, including occiput anterior, OA, occiput posterior, OP, and occiput transverse, OT. It's still under evaluation in larger trials, but it represents a novel approach aiming for safer assisted vaginal birth. #tag outro. What's really fascinating here, stepping back from all these details, is, it's the fine balance that defines this entire field. The constant tightrope walk between minimizing risk to both mother and baby and intervening effectively, sometimes rapidly, to expedite delivery when necessary. We've seen that true professional mastery hinges not just on executing a sophisticated technique perfectly, like, say, getting that 3-layer uterine suture just right in a cesarean, or applying the precise 11.5 centimeter cephalic curve with forceps, but it also hinges, perhaps even more so, on that critical judgment. Knowing exactly when the indications are met to start a procedure, and, maybe more importantly, knowing when the prerequisites aren't met, or when to recognize failure and abandon a procedure like that failed forceps attempt and transition decisively to a Caesarean section, that judgment is the safety net.
Yeah, that's a great point. And here's where it gets really interesting for me looking back at our journey today. We started with those foundational protocols, the mandatory asepsis, the bladder management, things that seem basic but are non-negotiable. Then we dove into the really complex, nuanced decision tree management required for something like uterine perforation. We analyzed the almost biomechanical engineering involved in forceps application, or the careful 3-layer closure of an LSCS. And we ended looking at the current standard of the Caesarean alongside promising new, potentially less traumatic technologies like the BD-Odon device. The sheer level of detail required for safe practice across all these procedures is just astounding. From knowing the 17.5 centimeter pelvic curve radius of specific forceps to recognizing those 4 distinct endpoints that signal a successful suction evacuation. So what does this all really mean for you, the learner, listening to this? I think it means recognizing that the complications we discussed, whether it's a devastating uterine scar rupture years down the line, or an immediate cervical laceration, or a late issue like perineal scar pain, these adverse outcomes are often directly traceable back to a failure, sometimes small, sometimes large, to fulfill one of those crucial prerequisites or follow one of those critical protocols we've detailed. Precision, adherence to protocol.
Sure.
It isn't just a goal in operative obstetrics. It really is the fundamental definition of safety in this entire field.
And that really raises an important question for the future, doesn't it? Given the undeniable global trend of increasing Caesarean section rates, alongside the sophisticated safety mechanisms that are now standard practice in major surgery, how will future obstetric practice and training balance this reliance on CS with the need to maintain and even enhance skills in safe, assisted vaginal birth? especially given that vaginal birth, even instrumentally assisted, often carries lower risks of maternal infection, hemorrhage, and thromboembolism, and allows for faster recovery. And how will potentially game-changing, low-trauma, instrumental delivery methods like the BD Odin device, if it proves successful, shift that balance in the coming years? That's the critical question, I think. How do we optimize safety while respecting patient choice and minimizing intervention where possible? That's something for all of us in the field and those entering it to really mull over.
Absolutely, a crucial balancing act indeed. Thank you for joining us on this extremely detailed deep dive into the world of operative obstetrics. We genuinely hope this has given you the mastery level foundation and the depth of understanding you were seeking.